Hereby, I open this academic ceremony in which Floris Verheij will defend the academic thesis Colorectal Cancer, Optimizing Treatment for Locally Advanced and Metastatic Disease. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you. Dear Pro-Rector, dear members of the degree committee, dear friends, dear family, thank you for traveling all this way to Maastricht. The title of my thesis is Colorectal Cancer, Optimizing Treatment for Locally Advanced and Metastatic Disease. And during the next 15 minutes, I'll be talking you through the research that I did for the last 4 years. Every year, 2 million people worldwide are diagnosed with colorectal cancer, and 1 million of these people die from this disease. And in the Netherlands alone, 12,000 patients are diagnosed with this disease yearly. And out of these cases, about 1/3 occur in the rectum. And the rectum is the last part of the large bowel. You can see on the picture on the right where the rectum is located. So when patients are diagnosed with colorectal cancer, we decide the stage of the disease in order to determine how extensive the cancer is. Here on the right, you see the insides of the large bowel. And stage 1, at this stage, the cancer has grown into the colon or rectal wall. In stage 2, the cancer has grown through the rectal or colon wall, but it hasn't spread to the lymph nodes yet. In stage 3, in this stage, the cancer has spread to the nearby lymph nodes. And in stage 4, this is the most advanced stage, the cancer has spread to the distant organs, such as the liver or the lungs, making it very difficult to treat. So for rectal cancer treatment, the treatment is as follows. For stage 1 disease, the primary treatment is surgery. For stage 2 and stage 3 disease, which we call sometimes locally advanced tumors, we give chemoradiotherapy. This means that we give chemotherapy and radiotherapy at the same time. This is followed by surgery. For metastatic disease, chemotherapy is the primary treatment, and some patients might benefit from surgery. In colon cancer, the stage 1 disease is treated by surgery primarily. In stage 2 and stage 3 disease, the patients undergo surgery and followed by selective chemotherapy. And similar to rectal cancer, stage 4 metastatic disease, patients are treated with chemotherapy and followed by surgery in some patients. So my thesis is divided into 2 parts. The first part is on rectum preservation, meaning that we treat the rectum, but we don't operate them. And not operating in the rectum might benefit patients because surgery has a lot of risks and complications for the patient. And in the second part, I will touch part 2 later in this talk. I'll discuss the unresectable and colorectal metastases. So as I described before, stage 2 and stage 3 disease are treated by chemoradiation. Patients get surgery afterwards, and we see in many patients that they end up with a permanent stoma. But more recently, we have discovered that some patients might respond so well to chemoradiation that all signs of cancer have disappeared. And it's likely that the cancer has disappeared completely, and the question is whether all of these patients need surgery. So in chapter 2, we studied the long-term outcomes of rectum preservation. Long-term outcomes means that we study these patients for multiple years. And in this particular case, we study whether not operating on these patients is safe. The organ preservation in rectal adenocarcinoma trial, also known as the OPERA trial, focused on stage 2 and stage 3 rectal cancer. And 10 years ago, on the exact day, April 12, 2014, the first patient was enrolled in this trial. And in 2020, the last patient was included. And the trial was conducted in 18 institutions in the United States and involved 324 patients. And patients received extra chemotherapy before surgery, and we know this as total neoadjuvant therapy. You will hear this term later in the talk as well. So 158 patients received either chemotherapy followed by chemoradiation, and 166 patients received chemoradiation followed by chemotherapy. For patients in which the tumor has disappeared completely, they went into a rectum preservation program, meaning that they didn't undergo surgery and they were followed very closely. For patients with obvious tumor still in the rectum after treatment, we recommended surgery. So beyond our expectations, we found that almost half of the patients were able to preserve their rectum, meaning that almost half of all the patients didn't need surgery. And the patients who got chemoradiotherapy followed by chemotherapy were found to be more likely to preserve the rectum. In 54% of these, the rectum was preserved, compared to 39% of the patients who started with chemotherapy followed by chemoradiation. In some patients, the tumor grows back, but we found that in the majority of the patients, those tumor regrowths occur within the first 2 years. But more importantly, we found that surgery after tumor regrowth resulted into a comparable survival with patients who underwent immediate surgery. In chapter 3, we studied how well patients tolerate their treatment. We call this compliance. And we studied what the harmful effects of chemotherapy and chemoradiation are. And we call this toxicity. We found that the toxicity levels between the treatment groups were similar. And we found that in those two different treatment groups, the patients followed their treatments equally well. Interestingly, we saw that women, female patients, and older patients were more likely to develop toxicity, so harmful effects after treatment. In chapter 4, we studied the lateral lymph nodes in rectal cancer. The most common lymph nodes that are involved in rectal cancer can be found close to the rectum. You can see it on the picture on the right. But in some patients, the lymph nodes can be found a little further from the tumor, and we call those lymph nodes lateral lymph nodes. These patients have a less favorable prognosis, and surgically removing those lymph nodes is very challenging both for the patients and for the surgeon. So we studied 57 patients from the OPERA trial who had these lateral lymph nodes, and we found that in over half of the patients who were treated with total neoadjuvant therapy, that those lymph nodes disappeared completely. Patients with lateral lymph nodes, on the other hand, were found to be less likely to preserve their rectum. So part 2 of my research is on treatment of unresectable colorectal metastases. Colorectal metastases means that the cancer from the large bowel has spread to other parts in the body, like the lung or the liver. And the term unresectable means that we cannot operate on these patients. It's either because there are multiple organs involved or because one organ, there's too much cancer in that specific organ. So about 20% of patients in clinic present with metastatic disease. And another 25 will develop metastases at a later stage. And we find the most common organ to be involved in this metastatic disease to be the liver. And the majority of these patients are unresectable, so we can't operate on them. We find that surgery to remove the primary tumor, so the original tumor, is unlikely to cure these patients. So the treatment is aimed at the metastases. In chapter 6 of my thesis, we studied whether not operating on these metastatic patients is safe. We studied 221 patients who had cancer spread to other parts of their body. They received chemotherapy, but they didn't undergo surgery. Among them, 109 patients had the tumor on the left side of the colon, and 112 had their tumor on the right side of the colon. We found that one in every 5 patients had a problem because of the primary tumor that resulted in them needing an emergency operation. The complications were more frequent in patients with a tumor on the left side, in 29%, than patients with a tumor on the right side, in only 13%. Hepatic arterial infusion pump therapy. In other words, liver chemo pump therapy. This is a treatment that was developed in Memorial Sloan Kettering in New York. And in this treatment, you surgically place a pump in the liver. And this liver chemo pump can deliver the chemotherapy straight into the liver. We use this for patients with unresectable metastases. And because we deliver the chemotherapy straight into the liver, we can deliver a 400 times higher dose than normal chemotherapy. In chapter 7, we studied if operating on the primary tumor and implanting a liver chemo pump to treat the metastases is safe. We included 258 patients who had a liver chemo pump placed and had their primary tumor removed, and there were 116 patients with only the pump placed. We found that it is safe to have the pump placed into the liver and have the primary removed at the same time. This will result in patients having to undergo only 1 operation instead of 2. In the last chapter of my thesis, chapter 8, we studied the outcomes of chemotherapy-naive patients who are treated with liver chemo pump therapy. We included 58 patients, and patients who never got any chemotherapy before are called chemotherapy-naive. We found that in 7% of the patients, all tumors disappeared completely, and that in 55% of the patients, the liver tumors shrunk and were able to be removed surgically. We found that these patients had very impressive long-term survival, with many patients living longer than 10 years. So we can conclude from this thesis that long-term rectum preservation is possible in almost half of the rectal cancer patients, that starting with chemoradiation followed by chemotherapy results in higher organ preservation rates. We found that left-sided colon tumors who have metastatic disease more often need surgery. We see that simultaneous resection of the primary tumor and placement of the pump is safe, and that after liver chemo pump therapy, that almost 2/3 of patients with initially unresectable disease can achieve a complete response or can undergo surgery. I would like to thank you all for your attention, and I would like to give the word back to the prolector.
Thank you very much for this very clear presentation. It is now time to start with the opposition, and the opposition will be opened by the chair of the assessment committee, Professor Olde Damink. He's professor of translational research in gastrointestinal surgery at Maastricht University.
Thank you, Mrs. Prorector. Dear candidates, congratulations with a fantastic brain thought stimulating thesis, and also congratulations to your promoters and your team that really started a lot of brain thoughts in my head. I tried to convince the committee to have the whole hour for me with all the questions that I have, but I wasn't allowed, so unfortunately it's only 7.5 minutes. The first question that I would like to ask you is what changed in the last 5 years? So your overview about the technical aspects of hepatic artery infusion, The last data set stopped 5 years. We will start the pump studies in Maastricht. What would you advise us? To do it robotically or open or with a laparoscopic approach?
Thank you, highly esteemed opponent, for your kind words and for your question. It's very exciting to see that there are new trials starting in the Netherlands and also abroad. The problem with the hepatic arterial infusion pump is that most of the data is from one side only, in Memorial Sloan Kettering. So it's very important that other sites start using this technique. And I think, if I understand your question correctly, over the last 5 years, there has been some change in treating those liver-dominant patients. What I advise is to do this for patients with liver metastases
no,
only.
it's just a technical question. It's just a very short. So there were 7 patients operated with robotic, and now robotic is really, catching on. Is your insight enough that most of the pump implantations are done with robotic assistance, or just during the open procedure?
So in the majority in the United States are done robotically, but I think the minimally invasive way of surgically implanting the pump would be the preferred way.
Good. Then that was also the idea we have in Maastricht to start it robotically. Yeah. Then, interestingly, you look at the post-op complications, and in chapter 8, page 116, you described that the perioperative data included operation time, estimated blood loss, and complications perioperatively. So, did you look at long-term complications of the hepatic artery infusion in these patients?
We didn't. We only looked at the short-term perioperative outcomes.
So, what would you expect that happens in 1 in 5 of these patients in the long term?
So these patients especially get complications from the bile ducts.
Yeah,
that's something that's good. Where we see very often.
What happens next if you have these complications, these cholangiopathies?
Yeah. So. What we see in the patients that we included in our study is that we stop the treatment for a while, and the advantage of the hepatic arterial infusion pump is that you can place it in the patient and you can leave it there for quite a while. There are some patients who might develop some complications like bile duct toxicity that stop their treatment, but you're able to leave the pump inside.
Do you know a similar surgical related procedure that ends up with the same percentage of cholangiopathies, and what is the treatment there?
The treatment, it's either removing surgically the pump that was placed,
or the whole liver,
or the entire.
And then
liver.
you do a.
Sorry?
And then you need to do
a liver transplantation. Yes.
So I looked up PubMed this morning, and there's only one paper out there from the Washington team, and they only described the technical feasibility in 6 patients after hepatic artery infusion for Auto-X. And it's especially because your catheter is in the hepatic artery, so also technical related. So it's a little bit more complicated, but feasible. None of the patients died. Now I would like to go to your results. In the Netherlands, we started a treatment program for people with unresected colorectal mets for liver transplantation. Do you know the inclusion criteria?
It's liver-confined disease and no extrahepatic disease.
Duration of stable disease is
I think at least a year.
6 months. So if you look at your median time of pump placement to conversion surgery was 6.2 months. Meaning that these patients are eligible for OTL for transplant. Then in your results, so of the 36 patients that received complete response, unfortunately 24 of them have recurrence intrahepatically. So what do you think was my thought this morning?
I think that these patients need a liver transplant.
There we go. So how you've got 2.5 minutes And this is the panel of the NWO, and you're here to defend your Feeney approach proposal, and you would like to have, what is it, 250,000 or 500,000 for your postdoc. First become a surgeon, but then, or clinical fellowship. So what would be your idea to design a study in which you use hepatic artery infusion, like we use Thesis in hepatocellular carcinoma, as a bridge to transplant? So what would be your idea about this?
I think I would design a study with chemotherapy-naive patients, so patients who don't have any surgery before, treat them with a pump. We see that after about 4 cycles of the chemo pump, most patients have a very good response. Then I would suggest doing a liver transplant after at least 6 months. Yeah.
And what would be the inclusion criteria? Because 7% of your patients group had a complete radiological response. What do we do with them? Do we want to expose them to a risky transplant, or?
I think I wouldn't risk them a transplant, because these patients do really well, and of these patients 2 have been alive for over 10 years without a liver transplant.
Yeah, agreed.
So I think,
But so if you look in the 36 patients, also 24 of them have extrahepatic metastasis, and that's something you don't want in an OLTX. So how would you exclude them? That's the last question. Short answer.
That makes it very challenging, this patient group. That's the biggest factor of that decides the prognosis of these patients. And I think in these patients, a liver transplant wouldn't be feasible. But that's a big problem in this.
So we conclude together, it is an option, but it's not easy. That's what I heard of your co-promoter, because he's thinking several years about this. And I'm happy to think with. So I'm very pleased with your answers. Very pleased with your answers, and I'll give back to the prorector.
Thank you very much, Professor Olderdaming. The opposition will be continued by Professor De Hing, Professor of Integral Approach of Patients with Gastrointestinal Malignancy at Maastricht University.
Well, thank you for the word, Mrs. Prorector. Dear candidate, please allow me to first congratulate you with your excellent thesis. In a relatively short time, many high impact journals, manuscripts, so congratulations on this, and of course also to your promotional team. I would like to start a discussion with Proposition 1, and maybe one of your paranyms can read it out to us.
De eerste. Long-term organ preservation may be achievable in half of rectal cancer patients. This thesis.
Well, thank you. That's a bold statement, especially since you write in your general discussion that this study, the OPA study, was the first study to show a real-world representation of organ preservation rate in rectal cancer patients. So you claim a high external validity of this study. Could you please explain this?
Highly esteemed opponent, thank you for your kind words and for your question. I agree that is a very bold statement, and I think we should see these results also in the context of an American healthcare system. And there are slight differences with the healthcare system in the Netherlands compared to the United States. We treat those stage 2 patients that we included in the OPERA trial quite different here in the Netherlands compared to the US. So I would expect half of these patients that we call locally advanced in the Netherlands would probably not be possible. But I think in a setting where you include those stage 2 patients and stage 3 patients, that half of those patients.
So your real world refers to the US and not to the Netherlands.
Yeah, well, if we decide to treat all patients with TNT, with stage 2 and stage 3 with TNT, we may achieve high organ preservation rates like this. But I think before we do that, we should look at what that does as toxicity, what it...
Yeah, exactly. Because I would like to challenge you a little bit on that, because you said there's a difference between the US and the Netherlands, But I took a look at your inclusion rate and to your characteristics in the trial. These are mentioned in, let me see, page 18, table 1. And especially what struck my attention is the age of your patients. Do you know why I found that interesting?
I believe it's relatively low. Yeah, it's relatively low age compared to the patients that we see in clinic in the Netherlands.
And is that a difference between the US or the Netherlands? I don't think so. I assume the age of rectal cancer patients might be similar. Might there have been a bias in selection of your patients?
I think you touch upon an important point. There may be some selection bias. The majority of those patients were included at Memorial Sloan Kettering, and the general population in New York is not very representative for everywhere in the United States. We did this research with other big hospitals in San Francisco and in other big cities, and I think more wealthy people live there who can afford better healthcare than the general American person. So I think there may be these patients that are included in our study may have some access to healthcare that some others don't.
Mm-hmm.
They might have an advantage.
Yeah. But why is age so important? You mentioned it yourself in the introduction, and it relates to complication rates. Mm-hmm. Can you explain why age might be important concerning the complications of your TNT treatment?
Yeah, like we showed in chapter 3, is that older patients just develop more toxicity than younger patients.
Yeah, and your patients in this trial are about 56, 59. Do you know the general age in the Netherlands from the Dutch Cancer Registry, the real world data, I would say? What would the age be in the Netherlands?
I have to apologize, I don't know it by head. I think it's closer to 60. 60.
No, it's way older actually. It's between 65 and 75, depending on how you look at it. But around 70 actually, the median age, so quite older than your population. And that might explain why in the Netherlands, in the same annual report of the Dutch Cancer Registry, the watch and rate strategy is only present in 26% of patients. What do you think? Is that a more let's say, a more honest reflection of real-world data, 26%, or do you really believe it should be 50%, also in the Netherlands, in patients with an average age of 70?
I think you have a really good question. I think we should maybe touch in the middle. I think with some improvements in the preoperative phase, the chemoradiation, we can maybe gain a little bit in the Netherlands for selected patients. Not every patient should have to undergo TNT, but I think we can gain a little bit and move slightly closer to the 47% that we present in the OPERA trial.
All right, so you would like to improve the patients for wait-and-see policy. I would totally agree with that. But how would you do that? And this is a little bit outside of your thesis, but you know in the Netherlands we have these normering. We have to perform 20 rectal surgeries in a hospital. That's not very motivating for a surgeon to refer them for wait-and-see policy. Do you think something should be changed there?
It's a really good question. You would expect the surgeon to not operate on a patient if they have a clinical complete response. And I think centralizing the healthcare maybe slightly more for complex rectal surgery might help. Mm-hmm. But I think I think in Holland I don't see a problem of surgeons operating on patients with a complete response, and I think we're getting there, that it's more accepted.
Well, there seems to be a big practice variation anyhow, so I like your optimistic ending of this discussion. I'm very pleased with your answers, and I would like to give the word back to the pro-rector.
Thank you very much, Professor De Hing. The open session will be continued by Professor De Wild, Professor of Surgical Oncology at Radboud University Medical Center, and he's present online. The floor is yours.
Yeah, thank you very much. Currently, I'm not in Nijmegen, but in the Caribbean, and this is New York time. So I was a little bit surprised that this defense is so early, especially for me, because it's almost 4 o'clock in the morning. But anyways, I would like to congratulate you with your very nice thesis and continue a little bit on the part that Professor De Hing was already discussing with you. Because in this chapter, and you have presented these very, very nice and very optimistic results of the OPERA trial, actually you finish in chapter 2 the discussion with future research should focus on more effective and less toxic neoadjuvant treatment regimens to further drive up the complete clinical response rates. How do you want to do this? Because I always think that if you want to improve complete response rates, you have to add something, and similar as adding the chemotherapy, and it usually gives extra toxicity. So how would you improve complete responses and decrease toxicity?
Highly esteemed opponent, thank you for your kind words and for your question. It is quite a contradicting statement. I agree with you in our discussion, but I think currently there are some amazing trials that are looking to increase the preoperative treatment, for example, in contact radiotherapy, or either adding chemotherapy before, and I think either contact radiotherapy or adding chemotherapy before surgery might add a little advantage in these patients to get a complete response. But I don't think doing a TNT for every patient is correct. I think in older patients we shouldn't give all of them 9 cycles of FOLFOX and chemoradiation. But there might be a chance for these patients with short contact radiotherapy or local excisions. These are all options that are currently being studied also in Holland. So I think these are options that we should look further into.
Yep. Because I mean, I absolutely agree with Professor De Hing that it is difficult to really consider the data you're presenting as real-world data. I mean, this is a very young, very good population we were studying in the US, and this is absolutely not comparable to real-world data. But the other thing that struck me was in chapter 3 that you are discussing about the toxicity of this TNT treatment, that you have actually also mortality of the patients you are treating with chemoradiation and chemotherapy. And this mortality was chapter 3, page 31. There were 5 patients who died of treatment-related toxicity, so that means approximately 2% mortality. And this is much higher than, for instance, in the Rapido trial, where they had a 0.5% mortality. So would you consider 5 times 5 as a less toxic treatment, for instance, in your TNT treatment?
Very good question, if I may answer.
Because you give chemoradiation in...
Repeat the last part?
No, because you give chemoradiation in the OPERA trial, and in the Rapido trial, it was 5 times 5 with systemic therapy. So could you consider this as a less toxic, for instance, neoadjuvant TNT treatment?
I think the toxicities with short course followed by chemotherapy compared with the consolidation group in the OPERA trial were pretty comparable, but I wouldn't treat these patients with a 5 times 5, since we see a slight increase in local recurrences. So I would suggest doing long course radiotherapy. But I do agree that the toxicity and the mortality in TNT is very significant. More patients die from chemotherapy and chemoradiation than they do from surgery. So I think that's something we should keep in mind as well. And there might be an option for patients with slightly higher mid to upper rectal cancer where we don't even need any chemoradiation or chemotherapy. And surgery might be sufficient in those patients if they can preserve the rectum. Yeah.
Yeah, I agree with that. So probably there's another way to really get organ preservation going, and you're making bold propositions actually, and perhaps I mean I realized you have a professional paranymph who already read one of the statements, but perhaps the other one can read the statement number 5, please.
Prevention and population screening are much effective for organ preservation in rectal cancer than total neoadjuvant therapy.
Now, that's a bold statement, because I think with population screening, this is quite a way to go. But what about prevention? So how do you think you can prevent colorectal cancer? Any ideas about that?
I think lifestyle is a big point that we can improve to get the incidence of colorectal cancer down. Patients with colorectal cancer are getting younger, which is a big problem that we're facing. And I think we should improve in lifestyle, in the food that people eat. I think there's much to gain there, and into screening and doing research on patients with either Lynch syndrome, and these kind of patients can be found more easily, I think. Yeah.
Yeah, I absolutely agree that lifestyle is the way to go, but this is difficult. Again, you have a very selective population that, for instance, can do a ride like you are doing in a few days. So this is only a selective group of patients. So it would be very interesting if a lot of Americans would, for instance, also take the bike and do something about BMI and obesity. Okay, let's proceed with another very interesting subject that you research with your team, and this is chapter 6. Because as you discussed in the Netherlands, we did a trial, the Cairo 4 trial, and I can tell you that it was finished a couple of months ago. We presented this last year at ASCO, and we have the final results showing no difference in overall survival of primary tumor resection versus starting with chemotherapy first. So actually the conclusion of our paper, and this was already years before proposed by Dr. Polzeit from the Memorial Sloan, is not to operate on those patients. Now, the last sentence again from your publication in the final conclusion is that patients with metastatic left-sided colorectal cancer should be informed about the high risk of complication if they choose not to undergo an upfront intervention. So what do you think you have to discuss with your patient? You leave them the choice of undergoing a surgical resection, or do you propose chemotherapy first in those patients with metastatic disease who you cannot cure?
Thank you for your question. And I was actually present during the ASCO meeting at the live meeting when these results of the Cairo 4 were presented. I was very impressed. I think the way to go for these patients is I would suggest in these patients to not undergo direct surgery. But I do think that patients have to know that if they have a left-sided tumor, that they have almost a 1/3 chance, at least in our retrospective study, a slightly higher chance of getting serious complications of the primary tumor. with perforation, with obstruction. So I think it's very important to tell that to a patient who, for patients who might have anxiety about the primary tumor, if they get into problems with the primary tumor. I think if you can find those patients, I think you can gain a lot there. But I agree with you that not operating on those patients is the preferred method. But for those left-sided tumors that do get more complications, I think we have to tell that to the patients.
Do you have any results about the ostomy rates?
Sorry, could you repeat that?
Do you have any results about the number of end colostomies that those patients received when they had these emergency surgeries?
Yeah, the majority had a diverting stoma. They either had a resection of the whole tumor and ended up with a stoma, and many patients had a diverting stoma. Yeah, I think the majority ended up.
Yeah. So that might also be a reason to discuss this with your patient, perhaps, that if you do it upfront, there is a very low chance of ending with a colostomy, so that you first, especially in the left-sided colon cancers, start with primary tumor resection, no stoma, and then continue with the chemotherapy?
I agree. I think having a patient who has a complication, needs a diverting stoma, I think post-operatively these patients are in very bad shape, and in these patients you just want to continue chemotherapy as soon as possible. So I think avoiding getting complications in these patients is very important. So I think doing a slightly earlier surgery with the chance of an anastomosis might help many patients. I agree.
I think my time is running up, and I have to give the word back to the pro-rector. I thank you very much for your answers. Finally, I have found an indication to perform surgery in your thesis, because every chapter is about not operating on patients, and you want to become a surgeon. So it's an interesting subject. I thank you very much for all the answers, and I give the word back to the pro-rector.
Thank you very much, Professor De Wild. We quickly go to the next opponent, Dr. Bolhuis, medical oncologist at Antonie van Leeuwenhoek ziekenhuis.
Thank you. I would like to start and congratulate you and your whole team with this impressive thesis. It's filled with very relevant and impactful research, and it will alter guidelines, so it's a huge achievement. As a medical oncologist, I expected a very hardcore surgical thesis, and I agree with my colleague that instead I found a lot of Kaplan-Meiers, and in every chapter you elaborated on chemotherapy, so I felt quite at home. I would like to start with an easy question. It's not a very hard one, but it's an important one. How often did you use the word surgery, and how often did you use the word chemotherapy in this thesis?
Esteemed opponent, thank you for your kind words and your question. I'm pretty sure the word chemotherapy was used more often in my thesis than the word surgery. Yeah.
Yes. I will help you, but you might want to consider a career switch, because surgery was used 150 times, and chemotherapy was used over 300 times. So that's quite a large difference. I would like to continue with chapter 2. It's one of my favorite topics. It's about initially unresectable colorectal liver metastasis. And you describe some promising outcomes in these patients after pump chemotherapy combined with systemic chemotherapy. We acknowledge the limitations of the study. It's a small cohort, and it's a retrospective cohort, but still I would like to draw a comparison with the Cairo 5 study. If you look at table 1, the patient characteristics, how would you describe this cohort? So what are prognostic factors of colorectal liver metastasis? And would you describe this cohort as low risk or high risk disease for recurrence?
Thank you for your question. I think if we look at the number of metastases at baseline, which is, I think out of the top of my head was 12, I think that's an indication that these are quite high-risk patients, comparable to I think they were in the COLORECTAL 5, the median was 13 or 14, but comparable to the COLORECTAL 5 trial. On the other hand, I think age is a relative low risk, or is a risk factor in these patients, and the median age in our group was 56, also very low. I think the majority had a left-sided colon tumor, which also has a slightly lower risk than patients with a right-sided colon tumor. So I think the number of metastases is high risk. I think the location of the primary tumor is more intermediate, lower risk in this cohort.
Yeah, and I also see that the majority is synchronous disease, over 90%, so that's also, I think, a high risk factor. And what did you think of the number of BRAF mutated tumors in your cohort?
I think there was the number was quite high in our cohort,
Yeah.
Slightly higher than, or quite higher than the incidence of BRAF mutations.
Yeah, it's much higher,
Yeah.
and you would expect that it would influence your survival. And indeed, it's quite comparable to the patient characteristics of the COLORECTAL 5, although the BRAF mutated tumors are much higher in your cohort. So how high was the clinical complete response and complete local treatment rate? And how high was the 3 years overall survival rate in your cohort?
Specifically for those BRAF patients?
No, for the cohort, so for the patients with complete local treatment.
The complete local treatment, so the complete responders, they had excellent survival. I think there's a few patients who were still alive after 10 years. And I think that's a group that needs further investigation. How come that after 4 cycles of chemotherapy, patients can get a complete response? I think that's very interesting.
Yeah.
And you have to remind me of the other 2
No,
questions.
I think we can continue on that. The 3-year also overall survival results are very impressive. In those patients after complete local treatment, it's 88%, and it's much higher than we know from historical cohorts. And also the complete local treatment rate is high. But so I think it's very promising, and I can't wait to start it in the Netherlands. But still, there was one outcome which I found a little bit disappointing, and that was the intrahepatic recurrence rate. So even after very intense liver-directed therapy, the intrahepatic recurrence rate was 67%. Well, you have had a quite high pathologic complete response rate. So do you have any thoughts on that, why those recurrence rates are high?
That's a good question. These patients have, from baseline, they have very bad baseline disease. And I think there can be gained much more from combining this therapy, hepatic artery infusion therapy, with maybe other modalities. The fact that some patients respond so well in such a small period might also indicate that the tumor growing back might also be very fast. So there's something in the biology in these patients who have a really good response at first, but have recurrence very soon after. There's something in the biology that needs to be examined further. And I don't have a answer for you right now, but I think maybe immunotherapy or other chemotherapy lines can help us with that.
Yeah. When we look at the patient characteristic, the intrahepatic recurrence rate, it's similar to the COLORECTAL study, but the survival is much longer of these patients after complete local treatment. So can you think of any disease or treatment-related factors of that recurrent disease which can explain that much longer survival outcome in patients who in your cohort?
Yeah, that's a good question. What we see in many of the patients that we place the pump is that they keep the pump for a longer period of time. And even after some patients have a complete response to the pump therapy, they keep the pump in the patient's body. And I think the fact that these patients live so long is that the recurrences are treated I wouldn't say easily, but you can treat those recurrences much easier with the pump still in place, with surgery. So I think many patients get recurrence, but we see that those recurrences can be treated quite effectively by either starting the pump again or doing liver resection of those specific parts where we see recurrences.
Yes, so even secondary liver resections, that rate was quite high. So it says something about how the disease recurs, the amount, the number of metastases and the location, and maybe that's changed by the pump therapy. Time is up. Okay, thank you for your questions.
Thank you very much, Dr. Bolhuis. The opposition will be continued by Dr. Smith, colorectal surgeon at Memorial Sloan Kettering Cancer Center in New York. Thank you for coming all the way to Maastricht. The floor is yours.
Thank you very much. Dear candidate, excellent presentation, audience, and committee, promoters, co-promoter. Thank you for the opportunity to oppose the candidate. So I'll start with essentially 3 topics, and whether you realize it or not, the 3 topics that you've covered, I'm picking 3 out of your multiple that you've presented, so congratulations on that. But the organ preservation will be and has become a paradigm-changing paper. The lateral lymph node paper that has recently been accepted for publications, congratulations. And then the coloanal anastomosis versus APR in those patients who essentially fail. So not everybody gets to preserve their organ to the audience, and so this is a really important paper. So when we think about the findings from the Oprah paper, how do you propose that we optimize response if the winner of the Oprah trial is your control? How would you propose we do that?
Esteemed opponent, thank you for your kind words and for your question. I think there is a really good trial that's has already started accruing in the United States right now that is attempting to increase the clinical complete response rate in these patients, and that might be adding irinotecan as in the pre-treatment phase for these patients. We see that in the PRO-D7 trial, that adding more chemotherapy might increase disease-free survival in some patients. And there might be a role of adding irinotecan preoperatively in getting a higher clinical complete response rate. So the GENES trial that is currently accruing is a really good trial that might increase the clinical complete response rates in these patients.
And then it was brought up in terms of validating these findings. How do you anticipate we best validate these findings if one of the weaknesses of the Oprah trial is that it's in highly selected groups in high volume centers in the United States? How do we best validate these findings?
I would suggest doing a collaboration with one of the institutes in Europe. I think there could be something gained there. I think maybe the institutes in Holland would be excited to do something like that with the United States. I think that would be a good way to go forward.
And then, as it relates to your findings from local regrowth, there's, I think, very profound implications for long-term surveillance. For example, you don't see any regrowths after 3 years. So how might you advise us on the implications for long-term surveillance for these patients?
Yeah, so our results show that the first 3 years are the most important in catching those early local regrowths. I would suggest doing a similar surveillance to surgery, where patients get seen after 5 years or up until 5 years. And I think after that, patients should go back into their screening program, like any other person does. And I think after 5 years, you have a pretty good estimate if a patient recurs or not. And it happens in the first 2 years in 94%, and only 1% after 3 years. So I think it would be wise to see them up until at least 5 years. And I think that's when you might call it safe. But we have seen some recurrences or regrowths even after 4 years, but these are very small numbers, and you see recurrences in patients that get operated after 5 or 6 years as well. So I think we can look at those similar. Yeah.
In regard to your findings for lateral lymph nodes, in the era of TNT, is it worth chasing these lateral lymph nodes surgically?
Surgically, with the data that we presented in our thesis, I think the benefit of doing a lateral lymph node dissection is very limited. We see in these patients that have lateral lymph node recurrences, all of them develop metastases. So these lateral lymph nodes, they are quite different from the mesorectal nodes. We see more metastases. So I will be reluctant into operating on all those patients with a visible lateral lymph node and doing a very extensive dissection. Yeah, I would.
And given the quality of life implications, somebody has an incomplete response, are you going to advise them to undergo colloidal anastomosis or an APR?
Yeah, and especially if a patient has a complete response in the rectum, but a visible lateral lymph node, would you take out the entire rectum just because there's a lateral lymph node? I think I wouldn't do that. No.
Thank you very much.
Thank you.
Thank you very much, Dr. Smith. Then just some minutes for the last opponent. That's Professor Beetstan, Professor of Radiology at Maastricht University.
Thank you very much, Prorector. So congratulations, candidates, and also the supervising team. It's a wonderful work. You've worked very hard, I know, even during the COVID time, so much respect for this. You're lucky because I'm the last one and I only have 1 minute. But probably you're not so lucky because I prepared a lot of questions. So maybe after this and maybe tomorrow, after another victory, I'm going to continue this opposition, if that's okay. But there's one thing that I would like to know now, and I would like you to explain to the audience. Maybe Peter, the paranym, can read proposition number 8.
How do you get to Carnegie Hall? Practice, practice, practice. New York pedestrian.
Okay, so dear candidate, I know you have a lot of talents. You're good in everything. But when I read this, I just was so surprised, because is this probably going to be the third hurdle that you're going to take to become a performer and a performer in the Carnegie Hall? So can you please explain to the audience what you're going to do after this victory this weekend, and what is the plan because of this proposition?
Thank you, highly esteemed opponent, for your kind words and for your question. Carnegie Hall will not be a place that you will find me in the future, I'm pretty sure. My musical talents or acting talents are I would leave to someone else. But there is something this weekend that I'm going to attempt. Is the Amstel Gold Race? It's not the Carnegie Hall, but I'm gonna try and do a good race there. So yeah, but Carnegie Hall is not going to be my place. No.
So it was just a joke.
Yeah.
Yeah, there was a joke. and I do believe that you can also conquer this Amstel Gold Race because you've done a lot, and I do believe you have a bright future. So I would like to close this and just give you a thought on chapter 2. I'm going to discuss it with you when you are relaxed this week or this weekend or after your next victory. I'm going to ask you a question on the response assessment. So with that, I would like to give back the word to the pro-rector.
Thank you.
Well, actually, we're waiting for the beetle to come. Oh, there she is. Let me see my text. Floris Verheij. The time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense, and I request that you and your company await the results of our deliberations and our return in this room.
Please all rise.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. I know what's on the line. I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
hier staan.
Ja.
Floris Verheij. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Bates is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise.
Belooft u dat u altijd volgens de beginselen... Oh nee, aan de andere kant. Engels. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Floris Stefanus Verheij, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university. Dear Dr. Verheij, Floris, I wonder how many Dr. Verheijs you have in the family right now. Is it 2 or 3? Two. You can be really proud of your achievement today. A fantastic collection of published papers on a highly relevant topic, and the committee just said they are practice changing, and we don't realize how much practice changing they are. So where did this start? With Floris, it was not like that he applied for a job opening we had as a young researcher. It was more of a thing that was growing organically in our department. Some years ago, our colorectal specialist nurses grew tired of scheduling and coordinating the follow-up of the growing cohort of watch and wait patients at the Netherlands Cancer Institute when we arrived there in 2015. And somehow the nurses, they created a job for a student to do this work. It was quite boring work. But that was when Floris appeared. So he was often working in one of these little rooms in our department. And he often asked me about some particular patients when they did not want the endoscopy, or they forgot the MRI, or there was no combined MRI slot, or the endoscopy unit says there is no space on Thursday. So I don't know what I replied, but I usually said, well, try to fix something, Floris. And somehow, most of the time, Floris managed to make it work. And that is one of its secrets. So Floris is always friendly and humble, but he has a highly valuable set of social skills. So he convinces people to help him or the patients, without giving the feeling to these people that they are actually pushed to do so. It is more like you seduce people to do the things you want them to do. So that worked in our department, and Julio also told me that you managed to make the statisticians and the data managers and all the people to come up with the things that you wanted from them. And they always worked for you. So, very valuable set of skills. So, he was working at our department doing this boring job, and he started casually mentioning he wanted to be a part of some of our surgical research project. And then, sort of under the radar, you became a part of our colorectal and liver group of surgeons. And your first project was on peritoneal metastasis. It was published in 2020 in the BJS Open with Niels as the main author. So that was your first paper, but we tried to fit it in your thesis. It didn't fit with the rest of the topics. And by that time, you had so many other papers that we decided to discard that paper. I believe it was in 2019 when, after talking to Julio, who I know very well, that we discussed the possibility of you going to Memorial Sloan Kettering for a couple of months. His father, Marcel, spent some time at the radiotherapy department at MSK, and you were actually born in New York at the time when your family was there. So you liked the idea very much. And the idea was to go for a short period of time, like I said, also because we had no real funding for you at that time. But Julio was kind enough to provide you with housing, and instead of a couple of months, it became a year. It was partly because it was the COVID pandemic, but it was also partly because you worked there very well, you liked it very much, and Julio and Josh, your other supervisor, they liked the work that you did very well. So because, as I mentioned, you have a highly valuable set of social skills, but in addition you are obviously also very intelligent and hardworking. So being in New York during the pandemic was quite challenging, but you made the best of it. So your housing was in the same building as the offices of Julio. And I believe you sometimes spend a week going from your room to the office and back without going out. And I have to thank Julio and Elsa for taking care of you at that difficult time too. Then you came back to us, and you went back for a second year in 2022 because you had so many projects that you had to finish. Now you were properly funded, and there were so many things. There was rectal cancer, there was the hepatic infusion pump, there were ideas on databases from MSK, there were ideas on databases from our side. And I remember with Julio and Niels and you talking, so we saw this list of plans of yours, and we had to cross out half of them because we also reminded you that you were still not a medical doctor. You were forgetting that you had to do your rotations and other things that you kept on postponing. I also have to thank, Regina and me have to thank you for taking care of our daughter over there, Natalie, when she went to Julio for her research project on the lateral nodes, which we're all happy that was last week published in the Annals of Surgery. Well, thank you for doing that, and thank you, Julio, for doing that too. And it is from our daughter that we know that you like Negroni very much and Chinese food. So if anyone in the audience ever needs a good place in New York for Chinese food, they should ask you. One last detail about today is that we were under a little pressure to make it happen today on the 12th of April, and I'm grateful for the university that they allowed me to bend the rules a little bit, and I'm grateful for the assessment committee that we pressured them a little bit. Because this weekend there is the Amstel Gold Race, and both Julio and you are avid cyclists, and tomorrow you're going to do the tour version of the Amstel Gold Race. I don't know which 60, 100?
We'll decide tomorrow.
Yes, you'll see tomorrow which one you take. So you're going to work on your primary prevention for colorectal cancer on your lifestyle tomorrow. So I wish you well tomorrow. I hope you do come out okay. So Floris, in December, last December, you became a medical doctor, MD, and now you come, it's actually a doctor of philosophy, it's a PhD. So I would like to doubly congratulate you for this, because it's worth noting that most people do their PhD after they become a medical doctor, and they do that full time, and so you combine that, which is a double effort. And in this congratulations, I would also like to extend this to your family who's sitting on the first row, to your girlfriend and your parents and your brothers and sisters. I don't know how many there are. So you are aiming for a surgical career. So you started the first steps. You still have to be admitted into a residency program. But seeing how you worked your way through your medical school and your PhD, I'm quite sure this is going to happen and it is going to go well. Thank you. Ik heb gezegd.
Yeah, dear Dr. Verheij, also on behalf of Maastricht University, I congratulate you with the degree you have obtained today. I also like to congratulate your family, your friends and colleagues who have obviously also been supported during your PhD trajectory. I congratulate your supervisors, Professor Bates, Professor Aguilar, and Dr. Kok with his good PhD defense, beautiful thesis. And I'd like to thank the committee here present for their contribution, especially our guests from outside, Professor De Wild from the Caribbean, Dr. Smith, present here, and Dr. Bolhuis. Thank you very much for coming to Maastricht and the time you have spent in this defense, because it's always a lot of time that you have to invest, and Maastricht University really appreciates that. Well, dear Dr. Verheij, I hope you feel relaxed now and that you're also satisfied with the way you defended your thesis. I can tell you that the committee was very happy with your defense. They thought it was high quality, and that your work is also very important. So take that with you in your future career. I wish you a lot of success in that future career, wherever it may bring you. And for tomorrow, good luck in the Amstel Gold Race. And finish safely. That's important. With this, I'd like to close this academic session. We are going to make a picture here. In the meantime, I ask the audience, except for the family, to leave the hall and go to the rafter for the reception, and we meet you there later, after making some pictures.
Ja. Mooi dat jij tegenwoordig avid cyclist bent.
Recording stopped. Supervisors, please come and join. Wagenems, please join and bring the degree.
Oh.